Our mission today is, it's a really fascinating one. We are basically going to be playing medical detective.
Right, which is always fun.
It is. You and I, along with the listener, are going to examine this massive, incredibly dense stack of clinical medical records.
And we're talking about Chapter 48 from a pretty heavy clinical microbiology text.
Exactly. It's 22 distinct real-world stories of the brutal, microscopic war between the human body and just an absolute army of invaders.
Bacteria, viruses, fungi, parasites, the whole spectrum.
The whole gang's here. Now, this deep dive is designed specifically for you, the learner. If you are someone who wants to understand the why behind medical diagnoses, but you don't want to drown in a sea of confusing medical jargon, you are in exactly the right place.
Yeah, we're keeping it accessible.
Right, because we aren't just going to read a list of symptoms. We're going to look at the battlefield of the human anatomy and really understand the strategy of these pathogens. So, okay, let's unpack this, starting with the very command center of the human body, the central nervous system.
If we connect this to the bigger picture, clinical medicine is, at its absolute core, a high-stakes game of pattern recognition.
Pattern recognition.
Exactly. What these medical records brilliantly demonstrate is how doctors take a seemingly random collection of physical clues, a patient's history, strange physical signs on their body, highly specific lab data, and they synthesize all of that to identify the exact microscopic pathogen causing the illness.
And when the central nervous system is under siege, time is, it's a luxury you just do not have.
You really don't. The brain and the spinal cord, they're designed to be a completely sterile fortress protected by the blood-brain barrier.
And when that barrier is breached,
the resulting inflammation isn't just uncomfortable, it is catastrophic.
Which brings us right to our very first scenario. And I gotta say, it's a terrifying one.
It really is a parent's worst nightmare.
Yeah. The story starts with a 3-year-old girl. She's brought to the ER by her frantic parents. For the past 24 hours, she's had a high fever, hasn't been eating. But the alarming part is that for the last 2 hours, they've had immense difficulty waking her up. She's profoundly somnolent.
Right. Altered mental status in a toddler is an immediate red flag.
The medical team finds a fever of 39.5 Celsius, over 103 Fahrenheit. But the real smoking gun, the clue that sets off all the alarms, is something called a positive Brzezinski sign.
A classic indicator.
Yeah, and to picture this for the listener, imagine the spinal cord and its protective coverings, the meninges. Imagine them acting like a tight string running from the top of the head all the way down the back.
A very irritated string.
Exactly. When those meninges are severely inflamed from an infection, they lose their elasticity. So when the doctor passively tilts the little girl's chin down towards her chest, it pulls on the top of that inflamed string.
And the resulting irritation is so intense that the body instinctively pulls the legs up towards the chest to relieve that agonizing tension.
It's an involuntary reflex.
It is. It's a brilliant, albeit tragic, biomechanical reflex. It definitively points to severe meningeal irritation. Because of this classic triad, the fever, altered mental status, and the Brzezinski sign, the team knows they have minutes, not hours, minutes.
So within 30 minutes of her arriving, they do a lumbar puncture, a spinal tap.
Right. They curl the patient on their side, carefully insert a needle into the lower back to draw out cerebrospinal fluid, or CSF.
Which is basically the moat surrounding the brain's fortress.
Exactly. And normally it should look exactly like clear water.
But hers was cloudy.
Which is a disastrous sign.
So they run the lab results on that cloudy fluid, and this is where the detective work shines. The data immediately pointed to purulent bacterial meningitis, totally ruling out a viral infection.
The reasoning here is fascinating. You look at the glucose level, the sugar in the fluid. It was dangerously low, only 15 milligrams per deciliter. Healthy is over 45.
So something is in there eating the sugar.
Yes. Bacteria are living inside that fluid, actively multiplying and consuming the sugar for energy. On top of that, her white blood cell count was off the charts, specifically the polymorphonuclear leukocytes, the PMNs.
The heavy infantry of the immune system.
Right. And that distinction is crucial. If this were viral meningitis, you'd typically see a moderate increase in a different immune cell, a lymphocyte. And the glucose usually stays normal because viruses don't eat sugar.
They just hijacked our cells.
Exactly. So knowing it's bacterial, the lab does a gram stain. Under the microscope, they see those massive PMN immune cells, and engulfed inside them, they find gram-negative diplococci.
Like two tiny kidney beans facing each other.
Yes. That visual signature is the absolute fingerprint of Neisseria meningitis. Because of this rapid-fire deduction, within 40 minutes, they start her on IV cefotaxime, a heavy-duty antibiotic, and dexamethasone, a steroid to blunt the brain swelling.
The speed of that scientific reasoning is breathtaking. It saved her life. But what I find really compelling is how the suspected invader changes entirely based on the demographic of the patient.
The medical playbook shifts depending on age. You always have to play the epidemiological odds.
Right, like for neonates, babies up to 3 months old.
For them, the prime suspects are totally different. You're looking at Group B streptococcus, or E. coli. Group B strep often colonizes the mother's reproductive tract and passes to the infant during birth. The baby's immune system is naive.
But then as they grow, the environment changes.
Right. For young adults, think a packed college dorm or military barracks Neisseria meningitis becomes the major threat because it spreads through close respiratory contact.
And then for the elderly.
It shifts again to streptococcus pneumonia. The immune system wanes, and bugs that normally cause pneumonia find a way into the bloodstream and up to the brain.
Which brings us perfectly to our next scenario. Talk about bugs traveling from one place to another. This one is mind-blowing.
The brain abscess case.
Yes. We move from a toddler to a 57-year-old man. He's brought in because he's having seizures. He's had a lingering headache for 3 weeks. But this morning, he started having focal seizures, uncontrolled movements specifically localized to the right side of his face and right arm.
And the history gives us the critical clue.
Right. They dig into his recent history and find out he had a dental extraction and some bridge work done about 5 weeks earlier. It's wild that a dentist visit can lead to a brain infection.
It sounds like science fiction, but the human mouth is an incredibly dense jungle. Hundreds of species of bacteria, normally harmless.
Our normal flora.
Yes. But a major dental procedure tears the gums, it disrupts the mucosal barriers, giving those bacteria a direct on-ramp into the bloodstream. Bacteremia.
So they get pumped everywhere.
Right. In his case, a few survived the journey, crossed the blood-brain barrier, and lodged in the brain tissue. The immune system went to war, tried to wall off the infection, and slowly created a growing abscess, a literal ball of pus in the brain.
Now, here is a massive, potentially lethal trap for the doctor. In the previous case, the lumbar puncture saved her life.
In this man's case, a lumbar puncture would likely kill him on the spot.
Let's break down the physics of that. Why is it lethal here?
It's basic fluid dynamics inside a rigid container. The human skull is a closed box of thick bone. It's perfectly filled by brain tissue, blood, and cerebrospinal fluid.
So if you add a foreign growing mass,
like a 1.5 centimeter abscess surrounded by swollen tissue, the pressure inside the skull rises dramatically. The brain is being squeezed.
and if you introduce a needle into the lower spine and drain fluid out,
You create a massive pressure gradient. High pressure in the skull, sudden low pressure vacuum in the spine. The physical force pushes the brain tissue downward, seeking the path of least resistance.
out the base of the skull.
The foramen magnum. The brain gets forced into that hole. It's called brain herniation. It instantly crushes the brainstem, which controls breathing and heartbeat. Immediate, catastrophic event.
So the doctors were astute. They checked his eyes, saw blurred optic discs, a sign of high pressure pushing against the back of the eyeball. They bypassed the spinal tap and went straight to a CT scan.
And the scan showed a localized ring-enhancing lesion in the left hemisphere, which explains the seizures on the right side of his body.
Because the left brain controls the right motor system.
Precisely. The neurosurgeons had to drill into the skull, carefully drain the highly pressurized lesion, and send that necrotic tissue to the lab.
And the pathogens, Prevotella meningogenica and Streptococcus aeruginosus.
Classic inhabitants of the human mouth. They're often polymicrobial, a team of different species that traveled together, combining metabolic tricks to survive in the brain.
It took surgical drainage and 6 grueling weeks of IV antibiotics to clear it. A profound reminder that a breach in the body's armor anywhere can have devastating consequences everywhere.
Which transitions us beautifully to the respiratory system. Section 2.
Yes, every breath you take. Here, the invaders aren't taking an elevator through the bloodstream. They're being inhaled directly. We have a classic presentation of bacterial pneumonia.
A 35-year-old man, an auto mechanic. He arrives in severe distress, high fever, shaking chill, and a sharp stabbing pain in his left chest every time he coughs or breathes deep.
Pleuritic chest pain.
Exactly. The membranes rubbing against the lungs are inflamed. We also know he struggles with alcoholism and heavy smoking. But the clinical detail that narrows the field is what he's coughing up. Thick, rust-colored sputum.
That rust color is such a visceral detail. Not yellow, not green. Rust.
It's a hallmark of deep alveolar destruction. The bacterial inflammation is so severe that the tiny capillaries surrounding the air sacs are bursting. Red blood cells leak into the alveoli, break down, mix with pus and bacteria.
You're literally coughing up the oxidized iron from your own blood.
Yes, and his chest X-ray showed a dense consolidation in the lower left lobe.
Let's visualize lobar consolidation for a second. Think of a healthy lung like a damp bath sponge. Mostly empty space for air. On an X-ray, it looks black.
And with the stethoscope, you hear a soft, breezy sound.
Right. But when it consolidates, those millions of microscopic air sacs are overwhelmed. The immune system floods the area with fluid and pus to drown bacteria. The sponge fills with concrete. On the X-ray, it's a solid white block.
The physical exam confirms it. When the doctor percusses taps on his back, it sounds dull, like tapping a barrel of water. And listening with the stethoscope, instead of a breeze, they hear crackling sounds. Rails.
The sound of him forcing air bubbles through that rust-colored sludge.
The lab isolated Streptococcus pneumonia. Now, why did a young man fall victim to this massive infection? His alcoholism is the critical vulnerability.
Because alcohol does multi-layered damage to our respiratory defenses. First, it depresses the central nervous system, dulling the gag reflex. He's much more likely to microaspirate his own microbe-rich saliva while passed out.
And chronic smoking and alcohol abuse paralyze the cilia, those microscopic hairs lining the respiratory tract that act like an escalator to sweep mucus up and out.
When the escalator breaks, the bacteria just slide right down.
Finally, alcohol directly impairs the alveolar macrophages, the immune cells that patrol the deep lung tissues. The alcohol intoxicates them. They become sluggish. The Streptococcus faced almost no resistance.
Luckily, he was treated with high-dose penicillin G and recovered. But contrast his violent localized infection with our next scenario.
The 68-year-old grandmother.
Right. She has lupus, takes immunosuppressants, she visits her grandkids, catches a mild head cold from a toddler, but it rapidly deteriorates into profound fatigue and severe shortness of breath, a stark contrast to the mechanic.
The differences guide the diagnosis. The mechanic had a sudden, violent onset, localized to one lobe, coughing up rust-colored pus. The grandmother's onset was gradual, body aches, low fever, and her cough is dry.
No purulent material.
And her X-ray doesn't show a solid block. It shows diffuse bilateral infiltrates. Hazy, patchy, white web-like spots spread out over both lungs.
Pointing away from a localized bacterial colony and towards a systemic viral pathogen. A rapid PCR swab led up positive for influenza A, H3N2, severe viral pneumonia.
Her immunosuppressants let the virus emerge right in. They gave her oxygen and a sultamivir to stop the virus from replicating. She stabilized.
This juxtaposition is why doctors rely on diagnostic matrices, like Table 4823 in the source. You have to look at where the patient acquired the illness. Both the mechanic and grandmother had community-acquired pneumonia, or CAP. They caught it in public.
But if a patient develops healthcare-associated pneumonia or HCAP, someone in a nursing home and dialysis center, the playbook completely changes.
Because healthcare facilities are basically evolutionary gymnasiums for bacteria.
Exactly. The surviving bacteria there are incredibly tough. You have to assume they might harbor multi-drug-resistant nightmares like MRSA or Pseudomonas. You bug out the heavy-hitting antibiotics immediately.
And we also have to mention atypical pneumonias. Mycoplasma pneumonia, the walking pneumonia, hazy X-rays, but the patients are literally walking around going to work, unaware their lungs are inflamed.
And Legionella pneumophila, Legionnaire's disease. The clue there is almost always environmental exposure to warm, stagnant, human-made water systems.
Cooling towers, large fountains.
Right. The AC aerosolizes the water into a mist, people inhale it, and the bacteria actually invade the alveolar macrophages and multiply inside them. It's an insidious survival mechanism.
The environment dictates the threat. Okay, let's move deeper inside the body. Section 3. Internal battlegrounds, heart and abdomen. This next scenario is an absolute masterclass in how a localized infection broadcasts visible clues across the whole body.
A 45-year-old woman admitted with a lingering low-grade fever, increasing shortness of breath, and a 5-kilogram weight loss over 6 weeks.
And a critical vulnerability in her past, childhood rheumatic fever.
The physician hears a new diastolic murmur over her heart, but the bizarre physical signs are what make this remarkable.
Textbook signs. Splinter hemorrhages under the nail beds. They look exactly like dark red wood splinters. Osler's nodes on the fleshy pads of her fingertips. tender, pupillish bumps.
And Roth spots in her eyes.
Hmm.
The doctor looks at her retina and sees pale, white, circular spots surrounded by a fiery red halo of hemorrhage.
What connects all these?
Infective endocarditis. Her childhood rheumatic fever caused chronic inflammation that permanently scarred the leaflets of her mitral valve.
Making it rough and jagged, like sticking Velcro to a wool sweater instead of a smooth pane of glass.
Perfect analogy. When normal mouth bacteria, like Streptococcus sanguinis from brushing her teeth too hard, enter the blood, they snag on that scarred valve. They multiply. The body sends platelets and fibrin to heal it, but it just creates a protected, chaotic mass of bacteria and clots called a vegetation.
Hanging right in the middle of the heart, the most violently turbulent environment in the body.
Dozens of contractions a minute. The sheer hydraulic pressure of the blood slamming against that vegetation causes microscopic infected clots emboli to break off.
And they get launched across the body.
They travel the arterial highway until the vessels get too narrow. They wedge into the capillaries under the fingernail splinter hemorrhage. They lodge in the retina, causing a mini stroke, the Roth spot.
And the Osler's nodes?
Those are localized immune complexes, antibodies reacting to the constant shower of bacteria in the skin vessels, and the heart murmur was the acoustic signature of blood churning over that massive vegetation. She needed 2 weeks of continuous IV penicillin and gentamicin to sterilize that valve.
Awe-inspiring how the body maps internal damage externally. Dropping down into the abdomen now, we look at peritonitis and abscesses. An 18-year-old student arrives doubled over in agony.
It started as a dull, generalized ache, but migrated to settle fiercely in his right lower quadrant.
The doctor presses deeply into that spot and then abruptly lets go. The student gasps in pain, rebound tenderness.
The gold standard clinical sign of peritonitis?
Because the peritoneum, the silk-like membrane lining the abdomen, is inflamed and exquisitely sensitive to stretching. The diagnosis is a ruptured appendix. In surgery, they suctioned out 300 milliliters of thick, foul-smelling pus.
The microbiology of a ruptured bowel is a highly coordinated two-stage ecological disaster. The gut has trillions of harmless bacteria, but the abdominal cavity outside the gut is supposed to be completely sterile.
When the appendix bursts, it spills them into that sterile space.
The first wave is driven by facultative anaerobes, primarily Escherichia coli. They can survive with or without oxygen. They spread rapidly, triggering massive inflammation, high fever, diffuse pain.
If untreated, they enter the blood, causing septic shock.
But as the E. coli multiplies, it aggressively consumes all the free oxygen in the abdomen.
Terraforming the environment for the second wave.
Yes, the abdomen becomes hypoxic, devoid of oxygen. This wakes up the strictly anaerobic bacteria that normally live deep in the large intestine. Oxygen is usually toxic to them, but now it's an oxygen-free paradise.
And the immune system tries to wall it off, creating an abscess.
The absolute king of this abscess stage is Bacteroides fragilis.
Which is why the pus was foul-smelling, right?
Yeah.
Because anaerobic metabolism ferments tissue, producing gas and short-chain fatty acids with putrid odors.
Exactly. He needed a surgical washout and a cocktail of antibiotics. One for the E. coli, and another, like metronidazole, to penetrate the abscess and wipe out the bacteroids.
Speaking of GI distress, Case 7 is a relatable nightmare. The family reunion potluck.
We've all looked suspiciously at potato salad in the sun.
4 family members get severe diarrhea and fevers. They all ate a specific dish prepared by a relative who just got over diarrhea. They got sick 36 hours later, and it evolved into bloody mucoid stools.
This explores the mechanics of foodborne illness. It's a spectrum based on pathogen strategy. The greatest clue is the timeline.
Right. If you're violently ill, 1 to 8 hours later, it's toxigenic. Staphylococcus aureus. The bacteria multiplied in the warm food and secreted a preformed toxin. You eat it, you're swallowing poison, it immediately hits the nausea centers in your brain.
Chemical warfare. But that doesn't fit our family. They took a day and a half to get sick and developed dysentery, high fevers, abdominal cramping, bloody stools.
Which points away from a toxin and toward a deeply invasive mechanism. The lab isolated Shigella flexneri. What is it doing for 36 hours?
Orchestrating a complex cellular invasion, it takes very few organisms to survive the stomach acid. Once in the large intestine, they actively hijack the epithelial cells lining the gut. They force the human cells to swallow them.
Wow.
They break out, multiply in the cytoplasm, and then propel themselves directly through the cell wall into the neighboring cell, spreading without ever exposing themselves to the immune system outside.
Horrifying. Using our cells as a highway.
Incredibly efficient. But the infected cells die and slough off. The immune system rushes PMNs to the area, causing massive inflammation. The tissue destruction and the battle shed blood and pus into the stool. That whole process takes 36 hours to build momentum.
And the public health takeaway is stark.
Yeah.
The relative was still shedding Shigella even after feeling better. Hand washing is the only defense.
Absolutely. Moving to Section 4, the plumbing, urinary tract infections.
We have a 21-year-old woman with a classic acute, uncomplicated bladder infection or cystitis, burning urination, dysuria, intense urgency, and pink urine.
Extremely common. 80 to 90% of these are caused by uropathogenic E. coli. Anatomy plays a huge role. The female urethra is short, close to the perianal area populated by bowel flora.
Local bacteria in the wrong neighborhood.
They migrate up to the sterile bladder. Normally, urinating would flush them out, but these specific E. coli have microscopic hair-like appendages called fimbriae.
Molecular grappling hooks.
Yes. They bind tightly to sugar receptors on the bladder wall. They anchor, multiply, and cause inflammation. The lab sees white blood cells and red blood cells, which made the urine pink.
The traditional threshold for a UTI is 100,000 colony-forming units, or a CFU, per milliliter. But clinical reality is different for symptomatic young women.
Right. If she has classic symptoms but only grows 1,000 CFU, 100 times less, the doctor still treats it as a definitive infection. The bacteria are there causing damage. A simple 3-day oral antibiotic wiped it out.
But that simple mechanism provides a terrifying baseline for Case 9. A complicated UTI where medical intervention complicates the plumbing. A 67-year-old man recovering from prostate surgery with an indwelling Foley catheter goes into septic shock.
The dark side of modern medicine. The catheter bypasses all natural anatomical defenses. It's a continuous physical highway for bacteria straight into the bladder, but worse, it's a foreign object.
And bacteria love plastic. Like the slimy coating on a rock in a riverbed, they form biofilms.
Biofilms are a microbiological superpower. They attach to the plastic and secrete a thick, slimy, sugary matrix, an impenetrable city. The patient's white blood cells can't penetrate it, and most IV antibiotics can't diffuse through the slime. The bacteria just sit inside, sharing genetic information.
And that shared genetic info is the nightmare. He caught a hospital-acquired, multi-drug-resistant strain of E. coli, resistant to gentamicin, fluoroquinolones, everything.
The clinical data highlights the global threat of ESBL-producing bacteria, extended-spectrum beta-lactamase. Standard antibiotics like penicillins destroy bacterial cell walls using a beta-lactam ring.
But the bacteria evolved a defense.
The ESBL enzyme. It acts like molecular scissors. When the antibiotic gets close, the enzyme snips the beta-lactam ring, neutralizing the drug instantly.
Because the drugs failed, the infection climbed up the ureters into the kidneys, pyelonephritis, and broke into the bloodstream, causing septic shock. His blood vessels dilated, trying to fight it everywhere at once, collapsing his blood pressure. They had to remove the catheter and use extreme last-resort carbapenems to save him.
A chilling reminder of the evolutionary arms race in hospitals, which takes us to Section 5, bone, tissue, and trauma, mechanical compromise of the body.
Case 10, osteomyelitis, a deep bone infection. A 34-year-old ATV rider crashes and suffers a horrific open fracture of his lower leg. The tibia pierces the skin, exposing bone marrow to dirt and skin flora.
The surgeons wash it, install metal plates and screws, but it refuses to heal. 3 weeks later, thick pus drains from the wound track. They culture it. Staphylococcus aureus.
The undisputed king of bone infections, normally a resident of human skin.
But incredibly destructive deep in tissue. Now, bone infections usually happen 2 ways. Hematogenous spread through the blood. Common in kids, a minor infection settles in the growth plates.
But this rider had a direct inoculation. The crash injected bacteria directly into the bone matrix.
And this creates a difficult anatomical problem. As the staph multiplies, inflammation increases pressure within the rigid bone casing. This physically cuts off the microscopic blood vessels feeding the bone cells. A section of the bone dies. This isolated island of dead, infected bone is called a sequestrum.
The ultimate bacterial safe house.
Because there's no active blood flow to the sequestrum, 5 antibiotics in the bloodstream can never reach the bacteria hiding inside. You could pump him full of drugs for a year, they'd just wait it out.
So treatment requires intense physical intervention.
The surgeons have to reopen the leg and physically scrape away debride every millimeter of dead soft tissue and bone. Chisel out the sequestrum until they see healthy bleeding margins. Only then can they apply bone grafts, new scaffolding, and 4 months of heavy IV antibiotics.
Brutal recovery. But scraping bone pales in comparison to Case 11. soft tissue infection, gas gangrene. A 22-year-old motorcyclist crushes his thigh in a collision.
Yeah.
Within 24 hours, unmanageable pain. The thigh swells massively, skin turns dark with large blisters.
The clinical indicator is terrifying. Crepitus.
If you press the swollen skin instead of firm muscle, you feel a distinct crackling sensation, like popping microscopic bubble wrap hidden under the tissue. That crackling is literal gas. The bacteria are producing gases that separate the muscle layers, and his red blood cell count is plummeting. Hemolysis.
The culprit is Clostridium perfringens. It operates on different biological rules. It's an obligate anaerobe. Normal, oxygenated blood is toxic to it.
So how does it cause this?
The crush injury. It crushed the arteries and veins, creating a massive zone of dead, oxygen-starved muscle tissue. Dirt from the road, contaminated with dormant Clostridium spores, got driven into that hypoxic zone. The spores wake up and multiply incredibly fast. They ferment the sugars in the dead muscle, producing hydrogen and carbon dioxide gas, tearing the tissue apart.
But the gas isn't the lethal part.
No, the gas is a byproduct. The true weapon is its chemical arsenal. It secretes devastating exotoxins, primarily alpha toxin. It's a phospholipase paste that dissolves cell membranes. It liquefies healthy muscle, destroys white blood cells, and shreds red blood cells.
It creates a rolling wave of necrosis, shutting down local blood supply so it can advance into newly dead tissue. It can advance inches per hour.
Relentless, systemic shock, organ failure. The young man tragically died 3 days later. The lesson here is brutal. Antibiotics alone are useless without blood flow. The only chance of survival is immediate radical surgical excision, high-level amputation, sever the dead breeding ground from the rest of the body, and use a hyperbaric oxygen chamber to force toxic oxygen into any remaining bacteria.
Deeply sobering. Moving to Section 6, a completely different threat. Sexually transmitted diseases. Stealthy, silent, profound, long-term damage. Case 12, a 19-year-old woman with dull abdominal pain and yellowish discharge. The pivot point is the pelvic exam. When the doctor touches her cervix, sudden, severe pain. Cervical motion tenderness.
A hallmark sign of pelvic inflammatory disease, or PID. The reproductive tract above the cervix is profoundly inflamed. They run a highly sensitive innate nucleic acid amplification test, positive for chlamydia trachomatis.
Chlamydia and gonorrhea are insidious. The initial infection on the cervix is often totally asymptomatic for months.
But it's an ascending infection. The bacteria slowly climb from the cervix into the uterus and out into the delicate fallopian tubes. This triggers a massive delayed immune response deep inside the pelvis, PID.
The long-term implication is heartbreaking. The immune battle causes severe collateral tissue damage. As it heals, it forms thick scar tissue, tubal occlusion,
The tube is permanently blocked.
preventing a fertilized egg from reaching the uterus, a leading cause of silent, permanent infertility, or an ectopic pregnancy if it gets stuck. The protocol is to test for both using that and hit them with a dual antibiotic strike immediately, ceftriaxone and azithromycin.
From ascending infections to localized ecological imbalances. Case 13. A 28-year-old woman with thin, whitish-gray discharge and a distinct fishy odor. Crucially, no itching, no pain, no inflammation.
The clinic tests are fascinating. The normal vaginal pH is acidic, below 4.5. Hers was elevated to 5.5. Then the whiff test. They add a drop of potassium hydroxide, KOH, to a smear of the fluid. It releases a strong, fishy amine odor.
Then they look under the microscope and spot clue cells. Normally, epithelial cells have crisp borders. A clue cell is heavily peppered with thousands of tiny bacteria, making the edges fuzzy and obscured.
But the critical observation is what's missing. No PMN white blood cells.
No immune response. This isn't vaginitis, which implies inflammation. It's bacterial vaginosis, BV, an ecological collapse.
Right. A healthy ecosystem is maintained by lactobacilli. The groundskeepers, they produce lactic acid. In BV, they crash. The pH rises, and opportunists like Gardnerella vaginalis overgrow like weeds, coating the cells and producing the odor.
The clinical matrix is helpful. If she had severe itch, yellow-green frothy discharge, thousands of PMNs and motile parasites, that's Trichomonas. If she had intense burning, thick, white cottage cheese discharge, but normal acidic pH, that's Candida, a yeast infection. Accuracy is everything. BV and Trichomonas need metronidazole. A yeast infection needs antifungal cream.
Case 14. A 21-year-old man with a sore on his penis. A firm bump eroded into an open ulcer with hard borders. But the detail that narrows the focus, it is completely 100% painless.
The diagnostic linchpin. Exquisitely painful ulcers suggest general herpes or chancroid, but a solitary, firm, painless ulcer is a chancre. the herald of primary syphilis caused by Treponema pallidum.
A bizarre corkscrew-shaped bacterium.
Very fragile. You can't grow it on a standard lab plate. To visualize it, the clinician uses dark field microscopy. They express a drop of clear fluid from the ulcer and light it from the sides against a black background. You can literally see the silver spiral spirochetes undulating and swimming.
Incredible. But the ulcer eventually heals on its own, even while spreading internally, so blood tests are complex. The reverse algorithm.
Syphilis triggers two types of antibodies. Historically, they ran a cheap, broad screening RPR test first. If positive, they ran a specific test targeting treponema antibodies. The reverse algorithm flips this.
Why?
Because the specific treponemal tests are now automated and highly sensitive. So they run the specific test first. If positive, it means exposure at some point in life. Then they run the general RPR to see if the infection is currently active or just a ghost from a past treatment. His lit up on both. Active infection.
Luckily, Treponema pallidum has never developed resistance to penicillin. A single, heavy intramuscular injection of long-acting benzathine penicillin cures it, preventing devastating neurological damage years later.
Let's unpack Section 7, the White Plague. Tuberculosis, still killing millions globally. Case 15 is classic pulmonary TB. A 64-year-old chronic alcoholic living in a crowded boarding house. Progressive weakness, massive weight loss, and drenching night sweats. A deep cough producing thick yellow sputum streaked with bright red blood.
The crowded boarding house is a massive red flag. Mycobacterium tuberculosis is airborne, spread via microscopic droplet nuclei when someone coughs. In a stuffy room, they hang in the air for hours. He inhaled them into his deep lungs.
The immune system responds but faces a problem. The bacterium has an incredibly thick, waxy, lipid-rich cell wall, immune to digestion by our alveolar macrophages. The garbage trucks swallow them, but the bacteria survive and multiply inside.
So the immune system shifts to containment. It builds a microscopic prison of fibrous tissue around the bacteria, a granuloma.
Sacrificing lung tissue to trap the enemy. The center of that granuloma dies, turning into a crumbly, cheese-like substance, caseous necrosis. If it expands and erodes into an airway, he coughs up that infectious sludge and blood. His X-ray showed a massive, dark, empty cavity in his upper right lobe.
The lab confirms with an acid-fast stain designed to penetrate that waxy armor. The slide is littered with bright pink bacilli. Treatment is a massive 4-drug regimen for 2 months. Isoniazid, rifampin, pyrazinamide, ethambutol, plus months more of 2 drugs. Why the carpet bombing?
TB grows incredibly slowly. Many bacteria in the granulomas go dormant. Most antibiotics only work on actively dividing bacteria. If you use one drug, the active ones die, but the sleeping ones wake up later and easily mutate to resist it. 4 drugs attack 4 completely different metabolic pathways simultaneously.
But 6 to 9 months of pills is grueling. Patients feel better and stop taking them, breeding multidrug-resistant TB, MDR-TB. So public health protocols use DOT, direct observed therapy. A nurse literally watches the patient swallow the pills every single day.
Now contrast that with case 16, where containment fails. A 31-year-old Asian woman, an immigrant. Profound fatigue, dry cough, high fevers. Her X-ray doesn't show one cavity, it looks like a snowstorm. Thousands of tiny, hazy white spots. Bilateral interstitial infiltrates. Enlarged liver and spleen.
The disease seeded her entire body. Biopsies of her liver and bone marrow are packed with granulomas. Disseminated miliary TB. The tiny granulomas look like millet seeds. The bacteria broke into her bloodstream.
Catastrophic systemic failure. But the fascinating twist is her diagnostic skin test. The PPD test injects TB protein under the skin. A healthy immune system recognizes it and forms a hard red bump. Her test was completely negative. Flat.
How can she be dying of TB and not react?
Energy. Her immune system is completely, overwhelmingly exhausted. Every T cell is locked in a losing battle against millions of granulomas. No reserves left for a skin bump.
The notes also mention she had the BCG vaccine as a child in the Philippines. That love-weakened strain can cause a false positive on a skin test in a healthy person.
Which is why modern diagnostics use blood tests called interferon gamma release assays, or IGRA tests. They measure the exact chemical distress signal white blood cells release when mixed with TB antigens in a lab. Incredibly precise and unaffected by the BCG vaccine.
Section 8 explores when the immune system is actively destroyed or suppressed. HIV and transplants. Case 17. A 44-year-old man with advanced AIDS. His CD4 T-cell count at tactical generals of the immune army has plummeted to 75. Healthy is 500 to 1500.
With the command structure gone, he's defenseless. Severe wasting, night sweats, unrelenting diarrhea. Blood cultures find Mycobacterium avium complex, MAC, a cousin of TB, but it's everywhere. Water, soil, dust, harmless to a healthy person.
But with CD4 below 200, it's an opportunistic infection, an environmental weed turning into an apex predator.
The list of these pathogens is harrowing. Below 100, cytomegalovirus, CMV, reactivates and attacks the retina, causing blindness. Pneumocystis jirovecii, a fungus, causes suffocating pneumonia. Toxoplasma gondii, a parasite from cat feces, creates massive brain lesions. Human herpes virus 8 causes Kaposi sarcoma purple vascular tumors.
To save him, doctors launched a dual counterattack, a 3-drug antibiotic regimen for the MA and highly active antiretroviral therapy to jam the HIV replication machinery, suppressing the viral load so his body can rebuild the CD4 cells.
The complex interplay of immune suppression is also in case 18 and 19 transplants. A 61-year-old gets a liver, a 30-year-old gets bone marrow. Doctors must purposefully blind the immune system with drugs so it doesn't reject the foreign tissue.
An incredibly dangerous balancing act. Too much suppression, fatal infection. Too little, fatal rejection.
Science has mapped a predictable timeline of infections post-transplant. In the first 30 days, threats are mechanical and bacterial, fresh surgical wounds, and massive immunosuppressants wipe out white blood cells neutropenia. The enemies are skin and gut bacteria, or Candida fungus.
Then, between days 30 and 90, the bacterial threats fade and viral threats awaken. Latent viruses.
Right. Our liver patient's new organs started failing. Not a surgical error, but CMV reactivating, causing viral hepatitis. They had to slightly lower his immunosuppressants and aggressively pump ID-ganciclovir to save the graft.
Beyond 6 months, chronic immunosuppression opens the door to late-stage fungal infections. Invasive aspergillus and environmental mold. It grows violently into lung tissue, causing hemorrhage. The bone marrow patient tragically developed aspergillus pneumonia, requiring highly toxic antifungal therapy.
Transplant medicine is a heavily calculated battle of antimicrobial shields and minute adjustments. Let's finish with Section 9, Global Emerging Threats. Zika, H1N1, Ebola.
In 2015, Brazil saw a febrile illness outbreak, mild rash, but then a massive spike in severe fetal abnormalities. Babies born with microcephaly brains and skulls failing to develop, and adults developing Guillain-Barré syndrome, ascending paralysis. Zika virus.
It wasn't new, identified in Uganda in 1947. But global travel dropped it into a completely naive population in South America with zero pre-existing immunity. And an active transmission vector, the Aedes aegypti mosquito, it ignited into a global health emergency.
The naive population principle also applies to the 2009 H1N1 influenza pandemic, a novel strain in California and Mexico, a quadruple reassortant swine flu with a chaotic genetic mix of North American swine, Eurasian swine, avian, and human flu viruses.
The flu virus has a segmented genome, 8 separate strips of RNA. If a pig is infected with multiple strains simultaneously, the viruses invade the same cell. They shuffle their RNA strips together like 2 decks of cards. The new virus has a genetic hand the human immune system has never seen.
It was so fit it outcompeted seasonal flu strains, sweeping the globe. And finally, the 2014 Ebola outbreak in West Africa, a hemorrhagic fever. It violently attacks blood vessel cells, leading to profound bleeding and fluid loss. A 64% case fatality rate. Whole healthcare systems collapsed.
When you look at Zika, H1N1, and Ebola, you have to look at human behavior. Global air travel spreads viruses in hours. High-density farming mixes segmented viruses. Human encroachment deep into animal habitats creates zoonotic spillover events. We're compressing the natural world and contacting pathogens we aren't prepared for.
Well, we have covered an immense, staggering amount of ground today. From the rigid fortress of the central nervous system to the fluid dynamics of the heart, deep into shattered bones, and out to global viral pandemics. I truly hope you, the listener, realize that symptoms are never just random discomfort. A fever, a pain, the color of a cough. These are precise clues left by microscopic invaders executing brilliant evolutionary strategies. The microbiology lab is where the real life-saving detective work happens. The next time you get a blood draw or a throat swab, you'll know the incredible chain of scientific reasoning it kicks off.
And I want to leave you with a thought that builds on all these miraculous antibiotic treatments. We've marveled at how medical science kills these pathogens. But consider this with the terrifying rise of multi-drug resistance, from ESBL, E. coli to extensively resistant TB, and global climates expanding mosquito habitats. Are we actually winning this evolutionary arms race? Or are our massive blunt force medical interventions simply applying intense pressure, forcing these microbes to mutate faster, share genetics quicker, and become infinitely smarter and deadlier? It's a complex, uncomfortable dynamic to ponder the next time you feel the chill of a fever coming on.
A sobering but absolutely necessary question. Thank you all so much for joining us on this expansive, fascinating deep dive through clinical microbiology. We appreciate you spending your time with us here as we unpack the science of survival. Until next time, stay curious and goodbye for now.